Good afternoon, buenas tardes, everyone. It is my pleasure here for to be in the today is what? Can you imagine? Today is the 19th day of our liver imaging series. We have an exciting lecture for a very important topic from a very nice and dear colleague, Dr. Alice Fung. It is my pleasure and honor to introduce Dr. Alice Fung. Dr. Alice Fung is an associate professor in the Department of Diagnostic Radiology at Oregon Health and Science University, not Oregon University, Oregon Health and Science University. She joined the Oregon Health and Science University faculty in September of 2007. Her specific area of interest includes CT colonography, image-guided procedures, MRI, and hepatobiliary imaging. She functions as part of the multidisciplinary hepatobiliary team at Oregon Health and Science University and serves as national and international committees related to liver imaging. Dr. Fung is the director of Body Imaging Fellowship at the Oregon Health and Science University, which offers subspecialty training in adult abdominal and pelvic imaging. Dr. Fung has also a special interest in diversity, serving as the University Affairs Committee and chairing the Diagnostic Radiology Diversity and Inclusion Committee to promote the richer environment where people of all backgrounds may feel welcomed and included at Oregon Health and Science University. So that's right to what we do here, because we have people from all over the world, our dear colleagues from all over the world. So that's great, Dr. Fung, for you leading this. In her free time, Dr. Fung enjoys exploring the Pacific Northwest, spending time with her family, curling up with a good book. So Pacific Northwest, that's why she doesn't want to come here to work in Houston. She hides her origin in Houston, and she thinks that Oregon is much better place for living. So Dr. Fung, we're all looking forward to listen to you today about MR imaging of hepatic adenomas, subtypes, and management.
All right, thank you, Khaled, for the kind introduction, and thank you so much for including me in this lecture series and putting this great course on. So today we're going to talk about MR imaging of hepatic adenomas with their subtypes and management. And I'll be reviewing the subtypes as well as delineating their distinguishing imaging characteristics, as well as talking about treatment and management of adenomas. So hepatocellular adenomas, they are benign liver tumors consisting of mature hepatocytes. They are the second most common benign tumor in a non-cirrhotic liver, FNH being the most common, and these are about 10 times less common than FNHs. These are lesions that are most commonly found in females of childbearing age. And they're thought to be hormonally driven with associations with oral contraceptives, as well as metabolic syndrome and anabolic steroids. So when OCPs first came on the market, they were pretty high dose, and the incidence of adenomas increased. With the decrease in the dose, the incidence of adenomas did not decrease, and it's thought because of obesity in this country has increased. So as far as general features goes, these lesions tend to be 1 to 20 centimeters in size, and they may be solitary or multifocal. Histologically, they are made up of benign hepatocytes that are in sheet or cord-like arrangements separated by dilated sinusoids and arterial feeding vessels that can hemorrhage or cause necrosis. And no portal venules or biliary ductals are noted within these lesions. Depending on what kind of subtype they are, they will have varying amounts of intracellular fat or glycogen. So the main risk factors or associations are, as we have talked about and we'll keep talking about, is oral contraceptive use, and anabolic steroid use, metabolic syndrome or obesity, alcohol abuse, and glycogen storage disease, specifically type 1 and type 3. And these patients with glycogen storage disease tend to be male and tend to present younger with multiple adenomas and have a higher risk for malignant change. Other associations include pregnancy, familial adenomatosis polyposis, beta thalassemia, type 1 diabetes, maturity onset of diabetes of youth. So knowing the background of your patient with the background of these associations helps us approach these images, because with a patient with these lesions oftentimes are nonspecific. And so when I'm looking at this lesion here, these lesions here, they are nonspecific, but I see that this is a woman. She is in her 40s and is taking oral contraceptive pills. And I also see that she is overweight and has hepatic steatosis. So that makes me put these lesions higher up on the, say that these lesions may be adenomas higher on the differential than, say, metastases because of that background. Another example is this patient here who has normal liver signal, but maybe the liver is a little bit enlarged. The caudate lobe has this lesion with that is mildly T2 hyperintense with some increased enhancement on the arterial phase and persistent enhancement. And then looking at his liver coronally, you can really see how big that liver actually is. It extends beyond the iliac crest. And I look in the patient's chart. This patient is a male with glycogen storage disease. So this nonspecific lesion will probably be an adenoma. So those are always helpful clues as far as how to characterize these lesions. So as far as using MRI as opposed to other modalities, we use MRI for subtyping because MRI has an increased sensitivity to the detection of intravoxel fat and microscopic fat. And so more so than like CT or ultrasound, and also the T2 characteristics and the different enhancement characteristics allow us to further subtype the lesions. As far as our protocol, it is basically a bread and butter MRI protocol, no new sequence, no extra hardware that is needed. So we have an in and out of phase T1, and then our pre and dynamic post-contrast T1 fat-satted images, optional delayed images for hepatobiliary agents, and then a T2 fat-sat sequence. So your basic liver mass protocol is needed. And then as far as whether or not to use gadoxetate for contrast, so as we know, normal hepatocytes and also hepatocytes and FNHs, they have these OAT-P, B1, B3 proteins that allow gadolinium to go into the hepatocyte, and so allowing them to enhance with gadoxetate administration. So when we are dealing with an adenoma, namely an HNF-1-a adenoma, these do not have those proteins, and so the gadolinium cannot get inside of the cell, and so the enhancement pattern is that there is no uptake on the hepatobiliary phase. So again, this is typical for hepatocyte and normal hepatocytes and focal nodular hyperplasias, that they do have the OP, B1, B3 proteins that allow gadolinium in. However, we have now found that some adenomas actually do express the OP proteins that are needed for the gadolinium, and so they do actually enhance on the hepatobiliary phase. And it is those adenomas that are beta-catenin activated that have this increased OP, B1, B3 expression. And so they do have increased signal during the hepatobiliary phase. These lesions are those that actually have increased risk for malignancy. So if we do see an adenoma that has this increased enhancement on the hepatobiliary phase, then that actually suggests that it is a higher risk subtype for malignant transformation. And we'll talk about that a little bit more. later on in the talk. So as far as subtypes goes, in 2006, a group of pathologists in Bordeaux, they discovered the subtypes. And then in 2016, EASL presented guidelines based on these subtypes because they not only do they have pathological distinctions, they also have features that change the risk of complication based on their subtypes. So the subtypes are clinically significant. So the main subtypes are inflammatory adenomas, hepatocyte nuclear factor 1 alpha inactivated or HNF-1 alpha hepatocellular adenomas, B-catenin-activated HCAs, and unclassified HCAs, which there's no known pathological way of discriminating these lesions. So in 2017, a year after these guidelines came, new additional subtypes were identified. That being that there's a mixed inflammatory and beta-catenin type and a sonic hedgehog adenoma subtype as well. And it was found also that these beta-catenins can be subdivided into axon 3 and axon 7-8 types. It's the axon 3s that have the increased malignant risk, where the axon 7-8s do not have an increased malignant transformation risk. And one word before we go on into the different subtypes about hepatic adenomatosis. The favorite terminology is now multiple hepatic adenomas rather than hepatic adenomatosis. And this is when we see patients with 10 or more adenomas. These patients don't tend to have known risk factors and they don't tend to be steroid dependent. A variable number of subtypes can be found within these patients, including inflammatory HNF-1 alpha and beta-catenin adenomas. The patients can be symptomatic because the lesions can progress, resulting in poor liver function, hemorrhage, and malignant change. So they can be more likely to have complications. And sometimes imaging does not have the resolution for locating all of the adenomas. Like in actuality, when you scroll through this study, you realize that there's like a cluster of probably 10, 20 in this cluster here and here. There are also microscopic adenomas that obviously we can't identify on imaging. So our first subtype is inflammatory adenomas, and they are the most common subtype, being 30 to 40% of all adenomas. OCP use is a strong association here, as well as obesity, hepatic steatosis, diabetes, alcohol, and glycogen storage disease. These patients typically present without symptoms, and so the lesions are found incidentally. Sometimes they can hemorrhage, and that is their presentation. Sometimes a patient presents with a systemic inflammatory syndrome where the patient will have fever, white count, elevated CRP level in the serum. And the systemic inflammatory syndrome can resolve once the inflammatory adenoma is resected. This type of adenoma also includes what we used to call telangiectatic focal nodular hyperplasia, which is now recognized as inflammatory hepatocellular adenomas. And histologically speaking, these lesions are sinusoidal, have a sinusoidal prominence, they have inflammatory cell infiltration, and they have tortuous and thickened arteries. So what do they look like on imaging? They typically are pretty strongly T2 hyperintense, and they have arterial hyperenhancement that persists on delayed images. So in this T2 fat-sided image, you have diffuse T2 hyperintensity with pretty strong arterial enhancement that persists on the delayed phases. And the combination of T2 hyperintensity with arterial enhancement is actually a pretty good are pretty good findings taken together, being 85 to 88% sensitive and 88 to 100% specific for inflammatory adenomas. Another good sign or recognized sign is the atoll sign, where you have T2 hyperintense rim with internal isointensity of central isointensity to the background liver. And here's another example of the atoll sign where you have peripheral rim, T2 hyperintensity, and centrally the lesion is isointense to the background liver. Another sign that has been recently described is called the crescent sign, where you have a rim of T2 hyperintensity with central steatosis or central remodeling. And here on the in and out of phase T1, you can see that there is a little bit of blood products representing prior hemorrhage, but you can also see that there is some internal fat or steatosis. Peripherally, the rim is T2 hyperintense, and then which enhances, and this is the delayed phase. So that is the crescent sign. And then here on the hepatobiliary phase, you can see that there is some increased signal within the lesion on the hepatobiliary phase. And this is thought to be the gadoxetate collecting or staying in the sinusoids rather than true uptake within the hepatocytes when it comes to inflammatory hepatic adenomas. Going on to HNF-1-alpha HCAs, this is the second most common subtype, representing 30 to 35% of all adenomas, and this is almost exclusively found in females. And again, strong association with OCP use. In one study, the cohort was made up of 90% people who have had a long-term history of OCP use that had adenomas. Other associations include maturity onset diabetes of the young and familial adenomatosis polyposis. So in general, these present indolently or incidentally because they have the lowest risk of a hemorrhage and lowest risk of malignant transformation. Histologically, the HNF-1-alpha inactivated prevents normal fatty acid transport within the hepatocyte, and so what happens is you get fat globules within the tumor cells with balloon degeneration of the hepatocytes. So the hallmark of the HNF-1-alpha subtype is the diffuse intravoxel fat. So as you can see in this in and out of phase study, you can see how starkly fatty this lesion is, and is very diffuse. This is actually a favorable prognostic indicator because the pathway towards a beta-catenin adenoma and a pathway towards HNF-1-alpha adenoma are mutually exclusive. So this cannot have beta-catenin activation here, which is increased, is suggested to be increased risk for malignant transformation. So this one sign of diffuse fat within the lesion is actually very good sign for an HNF-1-alpha adenoma. As far as enhancement characteristics, this lesion tends to be mildly arterially enhancing and tends to wash out on the delayed phases. So another example of a diffusely, strongly fat-containing lesion on the in and out of phase. And on the T2 signal is variable. It's usually mildly hyperintense or isointense, and it really depends on what the background liver fat content is like. And then enhancement pattern, as we said again, is mildly enhancing. So this lesion is iso-enhancing to the background liver on the arterial phase and washes out on the delayed phase. As far as the hepatobiliary phase, as expected, because there is no beta-catenin activation, which is associated with the OAT-P peptides that allow for gadoxetate to enter the hepatocytes. As expected, there is no hepatobiliary phase enhancement for the HNF-1-alpha adenomas. Going on to the beta-catenin activated adenomas, this is the third most common, representing 10 to 20% of adenomas. And they are associated with androgen use and more commonly seen with males. Glycogen storage disease and familial adenomatosis polyposis are also other associations. As far as presentation, this is the subtype that has the highest risk for malignant transformation. And histologically, sometimes it can be difficult to distinguish beta-catenin activated adenomas from hepatocellular carcinomas. As far as imaging, unfortunately, there is nothing distinctive imaging-wise to make us be able to say that, yes, this is a beta-catenin-activated lesion. There may be some intrafoxal fat, there may be some T2 hyperintensity. Usually there is arterial phase hyperenhancement with washout, and we have now recognized that increasing hepatobiliary phase signal suggests a higher malignancy risk. These features are the same as with the mixed inflammatory beta-catenin subtype. And maybe this mixed type may have some more inflammatory characteristics associated to them. So at my institution, since the time we started subtyping, we have not diagnosed a beta-catenin subtype, so I had to take these from the literature. And you can see that in this example, there is internal fat content, but it's not that strong diffuse fat content that you would expect with a HNF-1-alpha subtype. And there is arterial hyperenhancement as well as a significant uptake on the hepatobiliary phase, such that it is iso-intense to the background liver on the hepatobiliary phase. Another example from the literature is a lesion that is iso-intense to the background liver on fat-sat T2 with a central scar with also prominent uptake on the hepatobiliary phase. So what do we do about this uptake on hepatobiliary phase? Because when Gadoxetatic first came on the market, it was a black and white answer of yes, there is uptake, and that means it's FNH. No, there is not. That means it's more likely to be an adenoma. As we've learned more over the years, we realize it's not so cut and dry. And so some FNHs don't take up Gadoxetatic, and now we know that some hepatic adenomas do take up the contrast, and in fact, it's the ones that have the increased risk for malignancy that take up the contrast. So it's not going to be a black and white picture. It's more of what's the enhancement pattern of the lesion, and also what does the lesion look like on other sequences, and also what is the background clinical picture of this patient. So in this example, this is an FNH, and we can see that it's iso-intense to the background liver on T2 and T1 with that central scar that we really like to see. On the arterial phase, there's strong arterial phase enhancement and strong uptake on the hepatobiliary phase. And also there's kind of the striated pattern that we like to see in FNHs as well. This is in contrast distinction to this beta-catenin from the literature, where there is uptake on the hepatobiliary phase, and it's relatively strong compared to the background liver. It's at least iso-intense, but maybe a little bit more heterogeneous, and it doesn't have that architecture that we typically would expect for an FNH. So at the very least, maybe this warrants a biopsy to further characterize. This lesion here is a combined HCC adenoma lesion, and just by its sheer size, I think it would warrant further evaluation. And plus it's very heterogeneous and not typically FNH or adenoma necessarily. Another subtype is the sonic hedgehog, and this has been recently recognized as a subtype. It's associated with obesity and hepatic steatosis. It is the subtype with highest risk for bleed. And histologically, it is differentiated by its argininosuccinate synthase 1, which is associated with sonic hedgehog pathway activation. This subtype also does not have distinctive imaging characteristics that we've discovered as of yet. It can have increased T1 signal due to internal hemorrhage. It does arterially hyperenhance, but on the delayed phases, it has variable enhancement. So in this example, we have a heterogeneous T2 hyperintense lesion with heterogeneity internally. On the T1 weighted image, no interlesional fat, and then heterogeneous enhancement on the arterial phase with no washout, but washout on the hepatobiliary phase. This was deemed to be a sonic hedgehog lesion with internal blood products, which are not terribly obvious to me on the imaging. but that's what the pathologist reported back. And finally, we have the unclassified subtype, where this is basically a diagnosis of exclusion. There's no specific pathological way of subtyping it. There's no imaging characteristics or anything like that. So more to learn. And then finally, why do we care about subtyping these lesions? And it's because all of them have different risk of complications, the main complications being bleeding and malignant transformation. So as far as bleeding goes, there is a bleeding frequency of 27% overall of all adenomas, and about 17–18% of the bleeding is severe. Patient factors that increase the risk for bleeding include OCP use, as well as being overweight or obese. Lesional factors are lesions that are greater than 3.5 centimeters, located in the left lateral segment, are exophytic, or we can see the vessels on imaging going through the vessel or around the vessel. And then again, the sonic hedgehog subtype has increased risk for bleeding. As far as management, if the patient is hemodynamically stable, the patient should be counseled to discontinue their OCP use and should be surveyed for monitoring the size of the lesion. If the patient is unstable, then they are emergently embolized. And this is an example of a large bleed requiring embolization. It all remains subcapsular though, yeah, she was monitored after embolization and did well. So as far as malignant transformation into hepatocellular carcinoma, the subtypes are any of those lesions that contain the beta-catenin-activated mutation. And the malignancy is about 48% risk. Considerations include what's the health of the background liver, the clinical context, for example, as we talked about, those patients with glycogen storage disease have an increased risk of malignant transformation. If the clinical picture is a little bit atypical, such as it's a postmenopausal woman where we're seeing a lesion that kind of looks like an adenoma, but in a postmenopausal woman, that's kind of a red flag. So we'd have to further evaluate perhaps. The size consideration of over 5 centimeters has shown that that is increased risk in malignant transformation. So we use imaging to assess for growth and to assess for vascular invasion. So this is an example from 2013 where we have a lesion in the background of steatosis. It is enhancing on the arterial phase, and then there's some washout on the delayed phase, and maybe some internal enhancement or contrast in the sinusoids. The patient is followed up. The next imaging we see is in 2015, and the lesion has significantly grown. And so I don't know if they wanted to give a trial of OCP discontinuation, but she was followed up 4 months later, and it had hit the 5 centimeter threshold, and so they took it out and found that this was an HCC arising from an inflammatory adenoma. And I think looking back on this, we can see that there was a nodule and nodule appearance, and it's actually this part of the lesion that actually grew, and you can see the rest of the lesion is being compressed by that by the HCC. So this nodule and nodular appearance is something that we need to watch for as well. As far as management goes, EASL recommendations include discussion at a multidisciplinary tumor board, and all adenomas found in men should be resected because of their higher incidence of malignant transformation, and this is regardless of size or location. As far as women goes, women should be counseled to discontinue their OCP use and to lose weight and hope that the lesion will decrease in size. And these measures will also allow them to be better surgical candidates if that is the route that needs to be taken. Resection for all adenomas that are 5 centimeters or greater or show interval growth. And interval growth is based on the RECIST criteria, so it's 20% interval growth is what they recommend to assess it by. Multiple hepatocellular adenomas, so the management is governed by the largest or most suspicious lesion rather than all the taking all the lesions in conglomeration. As far as biopsy goes, so biopsy is a little bit controversial in that there is some heterogeneity within these lesions sometimes, and so there is always that concern for sampling error. So, so I guess we would only biopsy them at OHSU if there was anything suspicious about the lesion. Otherwise, we would just follow them up. As far as subtyping, or as far as subtype management, the beta-catenin lesions should all be resective, or curative treatment is defined by a surgical resection. Embolization is not considered adequate. All the other ones can be surveyed. And the surveillance schedule includes an MR every 6 months for 12 months, and then annually after that if the lesion stays stable or diminishes in size. It can be changed to biannually if the lesions remain stable. The patient can be converted to ultrasound surveillance if the lesions can be seen by ultrasound as well. And so here's an example of, in 2010, this adenoma was pretty sizable, but by 2013 it had shrunk considerably. And so I don't think we have lost her to follow up, but hopefully she's being followed elsewhere. So in conclusion, we need to approach these lesions knowing what the clinical picture is. Inflammatory adenomas are well identified by their T2 hyperintensity and their prominent arterial enhancement that persists on the delayed phases. The atoll sign and the crescent sign are good signs to identify inflammatory adenomas as well. HNF-1-a adenomas have that diffuse intralesional fat and are hypovascular. They also have good prognoses. No specific imaging features are noted for the beta-catenins or the sonic hedgehogs or the unclassified adenomas at this time. And as far as gadoxetate, potentially they can be a marker for increased risk for malignant transformation. So it is still important to assess lesions with gadoxetate if that is available. Complications, the sonic hedgehog subtype are the ones that are highest at risk for bleeding, and the beta-catenin, any sort of beta-catenin lesion has the highest risk for malignant transformation. As far as treatment goes, resection of all adenomas seen in males is recommended. Lifestyle changes for women, just to see whether or not these lesions will respond with discontinuation of OCP use and with weight loss. If the patient is not a surgical candidate, then embolization can be performed. Surveillance consists of MRI for every 6 months for about a year, and then once a year annually after that. And then ultrasound or biannual surveillance are options if the lesions remain stable or shrink in size. And that is it. And I'm open to any questions.
So thank you very much, Dr. Fung, for this informative lecture. This was really practical and informative.